Good afternoon, everybody. Good afternoon. It's a pleasure to see all of you here today, to see our students, our faculty, staff, and alums, and guests and friends. I'm delighted to be able to introduce our guest speaker today. This is our 19th annual Bonnie Bullough Lecture, and I know there's information about the lecture in your handout. But as you know, the lecture was created by Bonnie Bullough's husband, Vern, and Bonnie Bullough was a dean in the School of Nursing for a good long time, about 11 years. So with their generous support, we've been able to bring a noted guest lecturer in once a year. And today it is my delight and pleasure to be able to introduce a good friend and colleague, Dr. Lynn Sibley. I have a lot of things I could tell you about Lynn, but I know it's also in your handout, so I don't want to waste time doing that. I just want to tell you that Lynn is a poster child, I think, for what it really means to be a nurse and be a researcher. Lynn is a midwife. She's also an anthropologist, and she has married those two disciplines so beautifully in her research. She has worked globally most of her career and has done amazing things, particularly with bringing students into her research. So that's part of what we are in the School of Nursing, looking at how can we do that, how can we move our global initiative forward. And that's why one of the reasons I'm so excited to have Lynn with us today. So please join me in welcoming Dr. Lynn Sibley. You got water down.
Thank you so much, Marcia. It is truly, for me, a pleasure and an honor to be here, to be invited to give this lecture. And I have to say, seeing Marcia again is like I want to kidnap her. So you hang on to her. She's wonderful. I'm going to turn this roving thing on, so let me know if you can't hear me in the back. Just wave your hands. When I first spoke to Marcia, she asked if I would talk about sort of global partnership, students' engagement, and the experiences from our work in Bangladesh and Ethiopia. And when I sat and started preparing this talk, I realized there's not enough time to do both Bangladesh and Ethiopia. So what I've done is really focused on our current work and the work that led into the current work. And that is the Maternal and Newborn Health in Ethiopia Partnership that from this point on I'll call MANEP. So I will cover sort of the overall background of the project, looking at our partners and support systems, the sites, a little bit about intervention strategy and results, and then step back and look at the features that were important for its success, and also the relevance for other programming. And then I will take a look at new initiatives, academic engagement, and how we have brought students into this, because we've had a number of students who have used this as a platform for their own research, as well as faculty. And then sort of the growing pains of learning to do this work. It was very new to me and new to Emory's systems to have to be registered as an NGO. And I had to become a resident of Ethiopia, which was great, but it took forever. And so just the growing pains of figuring out how to support a platform of public health, intervention and intervention research. Most of you are probably somewhat familiar with Ethiopia. It's in the Horn of Africa. It is a beautiful country. It's quite diverse geographically and also culturally. It has 72 language groups. The predominant language is Amharic, and also English among educated people is a second language. They often have third and fourth languages. It's 83% rural still, consisting mostly of farmers and herders. That is shifting, but quite slowly. It's also the cradle of mankind. Ethiopia, and particularly the sites where we're working over in the far eastern part of the country, are the site of many hominid fossils, including Lucy. In fact, the district next to the one we're working in is where Lucy was found. So it's pretty exciting to be in that part of the world. The goal of our project was to reduce maternal and newborn mortality and to demonstrate a community-oriented approach to mortality reduction. It was a 3.5-year learning grant, and it was funded by the Gates Foundation, and we finished up in 2013. I think this was right after, Harsha, you came here. The overall project really was not something that was to be introduced from the outside. It was really something to help work with the Ministry of Health, under the auspices of the Ministry of Health, to help strengthen their health extension program. And this is their flagship program to extend the health services to rural areas. And a health extension worker is typically a young woman, but not always, with a 10th grade education, who has been trained in a package of 16 types of preventive care, everything from water and sanitation to building latrines to family planning to immunization. They had been trained in maternal and newborn health, but not given any practical experience. And when you looked at their training modules, it was really very scanty. So they were really viewed by the community as providers of maternal and newborn health, and they didn't see themselves as providers of maternal and newborn health, yet they were the vanguard. They were out there in the communities. Ethiopia has great needs in the area of maternal and newborn health. They have a developing health infrastructure. It is improving over time, but still, for example, in the area where we're currently working, there was no maternal and newborn health care being provided at the health center and health post levels. Women were not going in, and they didn't have providers with the confidence and competence to provide the care. So there's limited access given the topography. Ethiopia's about 2/3 of it are mountainous and serious access issues. About 10% of women give birth with a skilled attendant or in a health facility. So most births are at home with family members and sometimes a traditional midwife. And not surprisingly, there's been no reduction in maternal mortality in the last 10 years. And this data comes from Demographic and Health Survey of Ethiopia data. This is from 2011. So it's about 676 maternal deaths per 100,000 live births. And if you compare that to the US, which is around 9 to 10. Big discrepancy. And there's been a minimal reduction in the neonatal mortality rate. Ethiopia has achieved Millennium Development Goal 4, which is to reduce child mortality by 2/3 by this year. But that's been primarily in the 1 to 5 age group and not in the newborn periods. So as mortality decreases, newborns increasingly are a larger proportion of death in the childhood period. So we worked with the Ministry of Health and with 2 regional health bureaus, the Amara Regional Health Bureau and the Oromia Regional Health Bureau. These 2 regions together account for half of the population of the country. They're huge regions. We worked with the regional health bureaus to determine project sites. And they essentially, the Minister of Health selected the regions, the regional health bureaus selected the communities that we worked in. So we had 51 communities, and we worked with a vertical slice of each district's health system in order to link key personnel basically from the district hospital to health centers, all of the health posts under those health centers with community leadership, women and families. So by working with this slice, we actually had a structure for programming. And this was existing structure. The overall population was about 350,000 in both regions combined, and about 1,200 births per, or 12,000 births per year. We had an action theory for this project. We knew that frontline health workers, including the health extension workers that I just described, traditional birth attendants, which are women, older women usually who've learned midwifery by doing or by apprenticeship, and then community health workers who may have been involved in immunization or malaria control. There was little demand for their care and low capacity for maternal and newborn health. There were also cultural and logistical barriers to care seeking for labor and birth, and the health extension program was not fully operational. It was a new program, and the government of Ethiopia really put the infrastructure in place before the quality, and so it was kind of there but not very functional. We had a working hypothesis, given the statistics, that health extension workers were not likely to be in the home during birth. It was family members and traditional midwives. And that if we could facilitate their forming teams of frontline health workers and health extension workers, we would be more likely to get the health extension worker either into the home or have women come to a health facility for birth. And that if we were able to succeed in building these teams, then that would be a great platform for other health interventions. And the idea is that more, better, and more equitable interactions between frontline health workers, women, and families would lead to increased quality and coverage of care, and ultimately a reduction in mortality. The care package that we wanted to introduce, and again, we really are focusing on the birth to the first 2 days after birth, because that's when most mothers and newborns are going to die. It's the period of greatest vulnerability. So the care, and given that it was home-based care, the care was clean, safe delivery, prevention of postpartum hemorrhage using uterotonics, uterine massage, postpartum health assessment, counseling, and then also postnatal health assessment and counseling. This was the content both at facility level as well as at community level that we really wanted to try to impart. And we know that at 90% coverage, if you can get this package of care, certainly with respect to the newborn, you can reduce newborn mortality by about 38%. So the objectives were to improve the capacity of frontline health workers in what we call CMNH care, community maternal and newborn health care, increase the demand for CMNH care and improve self-care practices among women and family caregivers, and then to work with district leadership and line managers to develop model districts that are capable of continuously improving the care in the service of childbearing families. And if all these things could be successful, then we would be able to see every woman and newborn getting care in time, every time. And this really became the sort of the mantra of the project. All of our BCC, or behavior change communication materials said every woman and newborn in time, every time. It really caught on. Falling from those objectives, we had 3 intervention components that were really overlapping. We had the community maternal and newborn health training, we had collaborative quality improvement, and behavior change communications. And I'll go through each of these fairly quickly. In the CMNH training, we had 2 types. We had clinical refresher training for the health extension workers who, again, really didn't have any confidence or competence in their ability to provide safe, clean delivery in a facility or at home. And so we held that in a facility that was a referral facility, so they had an adequate volume of births. I mean, it's really hard when only 10% of your births in the country are in facilities, but we were able to find some referral hospitals to do that, and they were trained by MONEP clinicians with the support of the district health offices and hospitals. The second part was the community family meetings, and this is derived from our prior work in India and Ethiopia and Bangladesh, where it's community-based obstetric and newborn first aid care for women and family caregivers. So women in their second and third trimester of pregnancy come just like we would childbirth education preparation here, but the focus would be on emergency obstetric care and transport. And this was imparted by the frontline health workers who worked in pairs called guide teams at the community level. And this is actually even at the sub-community level. And this was supported by the district health office, health center staff, and coaches. Content of the meeting is very, very basic. The first meeting was just about an orientation to the program. It was a story called The Road to Life and the Road to Death. And this is a story of two families where the woman in each case develops bleeding during the late antenatal period. And it sort of follows the decision-making within each family as to what they did or what they didn't do, and then the outcome, where in one case one woman survived and the other didn't survive. And this meeting can be held in a community marketplace, it can be held in the home, it can be held anywhere. The next meeting is looking at what kind of problems do mothers and babies have that they can die from, and how do you recognize these problems, and then how do you safely take a woman from a remote village to a health center or a hospital where they can get care. Everything from cutting down trees to building a stretcher to trying to keep somebody hydrated while they're being transported. And then how do you prevent problems? Birth preparedness, complication readiness, immediate care during and after birth, and then postnatal care several days after birth. So these meetings were held in 4 sessions. The timing of the sessions was divided by the guide team and the families. In the initial part of the project, the families wanted to have the guides come to their homes, and so they did that, and the beauty of that is that other female relatives could hear the material, could practice. The traditional birth attendant could be there, the husband could be there, and so it was not unusual to have this happen in and around or after lunch, and so you would have everybody there, and they were all listening and learning the same thing. The program is skills-based, so it's really a process that we call interactive learning that really engages people. You start with reviewing if you've had a previous meeting. And if the problem is bleeding, for example, what do participants already know and do for the problem? We know that women can die from bleeding too much. Well, how do you already manage that? And sharing that, and then sharing what a trained health worker has learned to do. And then comparing, looking at what's similar, looking at what's different, reinforcing what's similar, and depending on what's different, if it's a harmless traditional practice, then supporting that practice. If it's something that really could cause harm, like pulling on the placenta to help it deliver, you would negotiate around maybe not doing that. And then practicing the agreed actions using pictorial checklist. With their family member who would be present, and then discussing how to know if the actions are helpful. How do you know you're making a difference? And then lastly, deciding how to prevent the problem in the first place. And we found that going into the emergency problem first and then talking about prevention works a lot better. We can talk about prevention, but people go, yeah, but they're really gripped by particularly bleeding and newborn resuscitation. You know, our baby has trouble breathing. So working the sequence this way, and we've tried it different ways, this is what really gets people. They get excited about it. So we have different kits and props. All of this can be produced, you know, certainly the props can be gotten in the local market and made, and the teams do make the resuscitation dolls when they're doing the community family meetings. But we have a manual, we have different props, and then you can see down in the lower right picture, our team member, they're doing a demonstration of a mother after birth. And he looks like he's getting ready to give her liquids. So for each of the major complications, there is a problem card. And on the front side of the card is the problem, and on the back side of the card, or the flip side, are the action steps to take. And this really is not rocket science, it's basic nursing care. So it's calling for help, getting together money and a stretcher, and hopefully they've done this ahead of time so that they're ready if emergencies happen. Doing external uterine massage to help the uterus to contract and slow down bleeding, doing nipple stimulation to do the same thing, helping to keep the bladder empty so that the uterus can contract and do its job. And then if it's not slowing down, doing external bimanual compression of the uterus to help slow down the bleeding, and then safely referring someone. If you, for example, have a laceration, we don't ask families to diagnose where the bleeding is coming from, but to put a pressure bandage on. So this is sort of an example of the materials. They use these Take Action cards during the training to coach each other, and then each family takes it home for reference during their own birth. And these cards, it's a visual literacy program, basically, and people are really happy to have these cards. And we've had pastoral association leaders come up and say, I can tell you the 5 steps to handle bleeding, and they said, this is important because we didn't know what to do before. And we would run and hide when our wife was in labor, and we were afraid she would have a problem and we wouldn't know what to do. And so they know that this is basic first aid. It's not the be-all, end-all, or cure-all, but it is something that people can do in preparation for referral. This is an example of one of the CMNH family meetings underway, and you can see this is the whole family's there. They've got their Take Action card booklet, and they're going through, through the meeting. And the guy that is standing up, he is a priest, and an Ethiopian Orthodox priest, and he's the guide team member. So the guide team members were included men, women, but people who really wanted to do the work. And in the lower right is our team, and they're looking at newborn care, with one of the Laerdal neonatally mannequins. We use those for resuscitation. This woman actually that's kneeling on the right, when we first field tested this, the community-based maternal and newborn health package in 2000, she was an 18-year-old, about 2 years out of her nursing program. And she came to this training and she was rolling her eyes, going, why am I here? She now is our senior nurse midwife specialist and running all of the sort of technical content of the current Ethiopia programs. She now has her own family and kids, but it's just been great to watch this woman blossom professionally. It's great. In terms of the intervention components, the next one is collaborative improvement. And collaborative improvement really is a group of people or teams of people that identify a common issue that they want to address and improve, coming together, coming up with ideas, going back and testing those ideas, coming back together, sharing what they've learned. It's a continuous improvement process. So we trained district coaches and village improvement teams. The coaches were drawn from the district health office and health center staff, so the nurses, midwives, and other line managers in the district health office. And the improvement teams were self-selected in the community, and it was really a cross-section of leadership. We had priests, we had imams, we had women's association leaders, pastoral association leaders, other women and families were represented on the QI teams, and also the TBAs and health extension workers. So the teams were about 12 to 15 people each for each village, and then there were 51 of these teams. The teams were supported by MONEP staff and consultants, and again with the support of the district health office and village administration. In terms of making sure that women get care in time every time in their newborns, it's not enough just to know the skills of safe, clean delivery, particularly in a community setting. So the improvement work focused on how do you identify a pregnant woman? Most women don't disclose their pregnancy until they're sure it's going to last, so usually into the second trimester, and you want to get them in early. So it's how do you identify pregnant women? How do you get them into antenatal care and get registered? How do you encourage them to attend the CMNH family meetings? When they go into labor, how do you let a health extension worker know that the woman is in labor so she can either get to the home to help with a delivery or know to follow up within 48 hours for postnatal care? Or if a woman's having a problem, to get to a health facility. So each of those areas became the focus of the quality improvement work. And for each, we ask, what are we trying to accomplish? How will we know that a change has occurred? What changes can we make that will result in improvement? And this is all the local ideas. These came from the communities themselves, from the QI teams and their work, not certainly from something that we wouldn't know. So they came up with the ideas. We helped them with how to test those ideas, how to monitor and document that. So they followed the same thing as from the Institute for Healthcare Improvement in Cambridge. The Plan, Do, Study, Act cycle, many of you may be familiar with that, but essentially it's a structured problem-solving process. where you actually plan what changes you want to try to make, and then you're going to try that during an action period. Then you're going to review your data and then make a decision whether to keep it, to add new activities, to try to figure out and tweak what works, documenting progress along the way. And it happens in a sequence of learning sessions. So about every 4 to 6 months, we would have a learning session where representatives from each of the guide teams, the quality improvement teams would come together and share their learning across, these different sites. And then they would come up with a new plan. They would get some additional training and improvement methodology, and then they would go back for another 4 to 6 months to practice their new improvement area. And at the very end of all of this, we combined, we had what we call a harvest meeting, and we combined the best ideas from all 51 villages in two regions and 6 districts to come up with what we call a change package. And then that went back to the teams so that they would have it. We've also used it now in the Afar region as well, and making tweaks to make it more culturally appropriate for that region. But just putting it all together, we have the learning sessions, the teams meet, the action periods where they test their ideas, and this is a continuous cycle ending in this improvement package. The learning sessions were truly amazing. I mean, we were all learning this by the seat of our pants. We were able to, with the funding in the project, to take an improvement advisors course. So we sent some of our team members, and I had the good fortune to also go, and IHI staff trained us. This was actually in Ghana. But then we came back and worked with our teams, the improvement teams. This slide shows one of the learning sessions and the data that the different QI teams have come back and they're posting. And then they have a session. You can see there are about 200 people here, mostly men. I mean, the men were very much involved in this. And so again, this group is, 3 to 4 members from each of the 51 QI teams. They're going around, they're discussing their data, they're talking about what worked, and they're setting what didn't work, what they might do differently next time. They're sharing across, and then they're planning for the next action period. This picture doesn't at all capture the absolute enthusiasm of these people doing this work. We, went from 8 supposedly to 5 o'clock, but it was often 9 or 10 before they were finished with their work. This was their community. They were going to go back and try these new ideas that they had come up with. Our team was, because then we would debrief after that, so everybody was totally wiped out. But it was just amazing. It was theirs. It was very neat. And then the last component of the project is behavior change communications, and we used a lot of sort of the traditional behavior change communication strategies, whether it was branded items like flashlights and umbrellas, things that were useful, to poetry contests, song contests, which are popular in Ethiopia. One of the more unique things that we did was this mobile video show. And I'll show you this. This, at first, when it was proposed, we thought, there's no way that's going to work. The topography is so difficult. How are you going to get a mobile van video around? But the team figured it out. And so we had a professional actors group come, and also local villagers participate in this. And the story here is based on that Road to Life, Road to Death from the Take Action cards. So in a way, it reinforces it, but it allows a broader population to actually see it.